So I thought I'd start with a 15-year summary of some of the rhetoric which has happened around HIV pharmacogenetics, starting with papers dating back to the early 21st century. And this, I thought, was quite interesting. Individualized therapy based on the genome sequence of each person will be realized in the next decade. And that was back in 2001. So I think we can agree that that hasn't happened. So there's been a lot of positive statements about pharmacogenetics. Maybe 2006, 2007, there was starting to be the realization that maybe pharmacogenetics wasn't going to deliver everything that it promised to deliver in the early years. And there started to be more of a realization that we, particularly for a pharmacokinetic phenotype, we needed to consider many more genes in concert with one another rather than looking at individual candidate genes. And some of the statements which were made then were alluding to the fact that the expansion of genomic technologies would enable us to cover much more ground and therefore really accelerate the pharmacogenetics predictors that could be implemented. Even up to 2014, and beyond actually, there's still many positive statements about pharmacogenetics. If we look at how publications have expanded over this time from 2001 through to 2015, a constant stream of increasing publications relating to HIV pharmacogenetics, up to around 40 to 50 publications per year by 2015. But obviously, we've also got to consider useful clinical implementation of pharmacogenetic tests. And it actually took me a long time to put the next figure together to show this. So Bacavir and HLA-B 5701. So I think there's a lot of literature surrounding pharmacogenetics, but there's very little in terms of translatable, implementable clinical tests. Having said that, we have learned a lot through the process of doing pharmacogenetic studies, and some of the science is just simply pretty cool. And so I'm going to spend some time talking through some of the data projects that David and I have worked on. Before I do that, I'll start with a study that Marco did very recently on looking at the relative genetic contribution to antiretroviral drugs. And really looking at relative genetic contribution in terms of expressing patient variability in terms of intra-patient variability, i.e. determining how much of the variability in pharmacokinetics is environmentally mediated versus how much of it is genetically mediated. And it's actually quite interesting to see that you can rank antiretroviral drugs based on the amount of their variability, which is potentially explained by the genetic component. And I think it's fair to say that efavirenz is the one with the highest relative genetic contribution, and that's borne out by the number of publications on efavirenz in terms of the genetics, and much of the work that we've been conducting over the last 10 years or so. The first paper, of course, was published by David Haas. I'm not sure whether David is still here. I know he had to take the plane out this evening. But it all started here with the finding that the 516G to T polymorphism was associated with efavirenz pharmacokinetics. And right from this first publication, it was obvious that there was an association also, at least with early CNS symptoms for efavirenz. David and I have published a number of papers since then as well, and and many other groups have as well, showing the same association between the 516T polymorphism and ephedrine's pharmacokinetics, but also other polymorphisms in cytochrome P452B6, such as the 983TC polymorphism. And then another publication showing that there were a number of factors associated with early discontinuation of ephedrines, and when you added these factors up, you got a good association with patients which discontinued therapy on ephedrines within the first 3 months of initiating their regimen. More recently, we've been doing a lot of the pharmacology within the ENCORE-1 study for ephedrines. The study, of course, which has assessed the potential for a dose reduction of ephedrines from 600 to 400 milligrams once daily. And I know that Laura Dickinson's in the audience here who did all the modeling on that. And again, the same association with CYP2B6 is borne out within the ENCORE-1 study, both at the 400 milligram ephedrines dose as well as the 600 milligram ephedrines dose. But again, no association at either 400 milligrams or 600 milligrams with the efficacy of ephedrines. So no association between the CYP2B6 genotype and the pharmacodynamics in terms of the efficacy. But there was an association between the polymorphisms within CYP2B6, CYP2A6, as well as the PXR nuclear receptor with the all-cause discontinuation and also with the CNS-mediated discontinuation of ephedrines. This is a paper published very recently by the group in Cape Town looking at, again, CYP2B6 genotype and in terms of viral suppression with ephedrines. And just to bring this bit out of the abstract here, again, ephedrines concentrations and baseline CD4 cell count, but not CYP2B6 genotype, were predictive of viral non-suppression. So again, we know there's a good relationship between the PK of ephedrines and the pharmacodynamics, but again, the genotype association just isn't good enough to make that prediction. And again, here showing that in this cohort, a lower minimum effective concentration was suggested down to be 0.7 mg per liter. This is quite interesting, and it's a physiologically based PK model that Marco created back in 2012. It was to predict the potential pharmacokinetics of ephedrines at the lower dose of 400 milligrams. So this was before the pharmacokinetic data was available from the ENCORE-1 study. And very recently, earlier this year, a validation of that model showing that there's a very good relationship between the wizardry that Marco did back in 2012 and the actual pharmacokinetics which was shown within the ENCORE-1 study. David and I have also done a number of studies more recently on ephedrines in collaboration with Adeniyi Olagunju, who's a fantastic scientist based out of Nigeria, looking at the pharmacokinetics of ephedrines during pregnancy and during postpartum. Again, associations between the CYP2B6 genotype, both during pregnancy as well as postpartum. Perhaps more interestingly, in terms of just an interesting finding, is that if we look here, a strong correlation between maternal plasma concentrations and concentrations of ephedrines in breast milk of breastfeeding mothers, And then an additionally strong correlation between breast milk concentrations of efavirenz and infant plasma concentrations. So showing that in some cases, infants are getting therapeutic exposure to efavirenz simply through the breast milk of their mothers. And that CYP2B6 genotype was associated with the maternal plasma concentrations, the breast milk plasma concentrations, as well as the infant plasma concentrations. But in addition to that, the infant CYP2B6 genotype was also independently associated with the infant's plasma concentrations as well. David and I have also done a lot of work together on the protease inhibitors. We were the first to show the association between SLCO1b1 polymorphisms and lopinavir plasma concentrations, and more recently showing the association of CYP3A5 STAR22 polymorphism and plasma concentrations of lopinavir. I wanted to do something a little bit more positive towards the end of my talk. So I'm going to talk a little bit about nanoformulations. I had to try and crowbar it in somehow. I guess when I first started hearing about the work of Viv and Janssen on the long-acting formulations, I assumed that the variability in the plasma concentrations would be lower than it would be for an oral formulation of these drugs, simply because you're avoiding the intestinal barrier and you're avoiding first-pass metabolism. But I went back and I took a look at all the long-acting formulations which are available, both in schizophrenia as well as for contraception, and as well as rilpivirine and cabotegravir. And I was actually quite surprised to see that the long-acting PK variability was as variable, if not more variable, than it was for the oral counterparts of these drugs. So that got me thinking a little bit about what the mechanisms were for drug release from an intramuscular depot. And the bottom line is we don't know. So there's many unanswered questions around this. This cartoon kind of shows the depot. We've got the solid drug nanoparticles here. The shaded area is the dissolving drug. We've got the muscle cells and the blood capillaries and the lymph capillaries. What we do know is that the epithelium or the endothelium around the blood capillaries has these intercellular clefts which are probably too small for the drug to actually enter the nanoparticles to enter the blood capillaries directly. But these are metabolically active cells. They have cytochrome P450 enzymes and transporters. Similar situation in the lymph, except in some cases these intercellular clefts can be up to 2 microns wide. So in the case of lymph, it is potentially possible for the particles to enter the lymph, which ultimately dumps into the systemic circulation at the left subclavian vein. So there is a potential for particles to come in. We also know that soon after depot administration, macrophages infiltrate the depot. These macrophages are able to phagocytose the particles, and soon after form a granuloma around the depot, which can restrict drug release. So the other thing that we've done very recently is we've started looking at the pharmacogenetics of oral rilpivirine. And we've got an early hint that the CYP3A4 STAR22 polymorphism is associated with oral pharmacokinetics of rilpivirine. So what about with a long-acting formulation? Well, I think it's potential, at least. I mean, again, this association is not even as strong as the CYP2B6 association with efavirenz, so it's unlikely to be implementable for rilpivirine oral. But if we apply the same relationship to the PK of the long-acting rilpivirine and extrapolate, I think there's a potential, at least, to have a personalized frequency of dosing. So maybe 4 weeks in one patient versus 6 weeks in another patient. And I think that's something which we'd be interested in to look at going forward. It might be even more marked because many of these sites have been shown to express CYP3A4, so CYP3A4 might be important within the depot itself. I'm going to leave it there, but I wanted to finish with a picture of David giving a presentation. I think that's a great picture of David. Kim's already spoken about his profile, first paper in 1971, 45 years worth of publications. I spoke about 14 papers in this presentation. David's been instrumental to 11 of them. But let's look at his publications over time. So there's his publications back in 1971, all the way up to 2016. I got to ask the question, what happened in the 80s, David? You were publishing like a mere mortal. And again, in the late 90s. You can tell me over a beer later. So I leave it there with some acknowledgements. The fantastic team in Liverpool, our very long, strong collaboration with the Torino group, and all the people that have funded us.